Good, sir. So we have one last talk. I would like to invite Dr. Pratyush. Dr. Pratyush is going to talk to us about transconjunctival SICS. Dr. Pratyush, are you around? Okay, so looks like he...
No, Dr. Pratyush has started sharing his screen.
I think he is busy in the OPD and he is managing both patient and
yes. I was actually walking on two boats. Yes.
Yeah, we can see your screen. Dr. Pratyush, you can start the presentation.
Yeah. Hi, everyone. Good evening. And I'm Dr. Pratyush. I'm joining from Varanasi. First of all, happy Mahashivratri to all of you. Today is Mahashivratri, the biggest festival in Varanasi. Still, we have lots of patients today. So generally on festivals, Varanasi people have a different attitude. They visit more on holidays. They won't rest at home. So I'm going to talk about this transconjunctival SICS, which I also called modified manual small incision cataract surgery, that is RMSICS. So what we have done in this surgery is that we have removed all the unnecessary steps so that this could be done quickly. Obviously, the idea is not to finish it quickly. Idea is to do it, in a high volume setting, in a good surgery in a less amount of time. So, and with an instrument which I have innovated, the astigmatism can also be tackled during the SICS surgery itself. So what are the modifications? There are 5 modifications in transconjunctival surgery. There is no injectable anesthesia. So I'm doing it under topical anesthesia. So, and there is no superior rectus brittle suture. There is no conjunctival flap, and the construction of sclerocorneal tunnel is through the Ranjanamyces marker. And I'm in all cases I'm implanting under hydro. So that's the changes. Superior rectus brittle suture, as we all know, is an unnecessary step. After some point of time, you gain enough control over the eye to know that you don't need actually that. And I'm very thankful to Dr. Devashish Bhattacharya, Disha Eye Hospital, Kolkata, who introduced me to this 0.2 mm epsilon eye care forceps, which was really making globe stable during the scleral incision for the SICS. But then again, I was having a lot of issues. So I went on to this innovate Ranjanamyces marker. So the advantages of having transconjunctival surgery is that a precious limbal cells are preserved. The cautery-induced complications like scleral melt and induction of post-operative astigmatism due to tissue shrinkage is completely avoided. The active bleed at the conjunctival site and preserved epithelial tissue help in quicker healing. And it obviously shortens surgery times, which is very helpful in anxious patients. And obviously, the disadvantages are with the young surgeon not very confident in SICS. This bleeding can disturb them in the initial phases, and then incomplete cutting of conjunctiva will lead to an incision drag, and that can complicate the matter. So Ranjanamyces marker actually helps in 3 critical steps. It has a 360-degree serrated edges that will stabilize the globe. There is a tunnel marker. You exactly know that you are from 2 mm away from the limbus and your incision is perfect round shape. It's like a stencils, you are doing this. And you also have a corneal axis marker. So you know where is the steep axis, and you plan your incision accordingly, like Dr. Boramani is doing. So We are planning that on the cornea itself. And hydroimplantation obviously has its own advantages, and that many of us are now doing. Even with our phaco patients, we are doing a hydroimplantation that saves a lot of time and a lot of tasks, which recently was a nationwide phenomena. Fortunately, I didn't had any because I used the visco only once, only during the rhexis formation. So now let's have that look at the surgery. So this is the Ranjan MICS marker. So this marker is stabilizing the globe. And like a stencil, I am cutting the conjunctiva and sclera in one go. So if there is an incomplete cut, you can again do it. And once this initial incision is made, we would proceed with the tunnel making. I'm using epsilon 0.2 mm incision to stabilize the globe during this part. Instead of hydro, I feel putting a decongest drop during surgery makes it more beautiful at the end. So you have a white eye topical SICS with a very shiny cornea. So this is the transconjunctival making of tunnel. And then the rest of the steps are almost same. I have modified as I told you. So only during rhexis formation I do this visco injection. Otherwise, rest of the surgery is only under hydro, including the lens implantation. So rest of the surgery is same. I think I don't have to show you the whole surgery. Let's come to this lens delivery part, again under hydro. Sometimes I require irrigating vectis after disengaging lens. And once this is out, cortical cleaning. And once cortex is cleaned, the lens is put under hydro. So from the side port, the Simpo is there. And from the main port, the lens is going. So with lens in place, this conjunctiva which was cut there is put in place by small cautery. So just a cautery closure of conjunctiva at the end. So this I'm making it here. I'm holding it, cauterizing it a little bit. 2, 3 such. So that's it. It's sealed now. So that's all I have to show. This is pre-op result, and probably on the next day we had a very fantastic result, because SICS does wonders to cornea, unlike phaco. So thank you very much. If any questions, I would love to answer.
Thank you, Dr. Pratyush, for that wonderful talk. And we always love to see that Ranjan marker that you show. And yes, the results in SICS are excellent, comparable to any other cataract surgery. So as we come to the end of this session, we've had a galaxy of speakers, Dr. Pratyush, Dr. Kimaya, Dr. Santosh Bhide, Dr. M.S. Ravindran sir, Dr. Shekhar Paranse, Dr. Nivian, Dr. Neeta, Dr. Manik, who showed many new things, Dr. Ashok Nanda. So from ISMS ICS and from Dr. Sahu and Dr. Boramani, we would like to thank the AIOS, Dr. Lalit Verma, Dr. Namrata Sharma for giving us this opportunity.